Good evening, everyone. Here Imran Abbas again. We are live. I am live from Dubai, and really today, someone who is with us, who is a real legend, live legend in field of bariatric surgery, and one of the best in Runway gastric bypass. And you can't believe this was my dream to interview Professor Bruno Dillemans. And today we have live Professor Bruno Dillemans, and unbelievable how much I am excited, and definitely don't miss this session. We will have same repeated question, but you will see the answers. So this is our target of interview series because we have such a legendary professor. Professor Dillemans is with us till 1 hour. And if you have any question, you can ask directly. You can ask in comments. And so in my opinion, tonight, it will be one of the best session. Sir, I will not take time. Over to you, sir.
Thank you very much for your invitation back again, Imran. We just recently met each other because I was not aware of your, I would say, predominant presence, not only on the web forums, but also surgically. You do remember that on the live surgical procedure, you visited me, you give some good advice, you also, I think, are a strong surgical profiled person, a doctor. So I do remember you on that part, that not only it's regarding have presentations and talk, but I think, you had a lot of skills as well in yourself. You're very humble and thanks for that to be present for everybody. So my name is Bruno Dillemans. Thank you again for this nice introduction. They also asked me, what is a bit the summary of my career? I have to say, frankly, I've been graduated very shortly in 1986 as a medical doctor with great distinction. Then I went to surgery for 8 years. 4 years I went to a peripheral surgical clinic, Rohingya in Belgium, where I really learned quite well to work hard and to develop good skills, and 4 years in continuity. Then 2 years consecutively, I went to the University of Leuven in Belgium, which I think is, if I may say that, I have to be very careful, the highest profile university hospital in Belgium. And then after those 6 years, I went additional 2 years to the north of the Netherlands, Groningen, University of Groningen. And so I think I finished there in 1994. And I have to say that I was very lucky at that stage that I was a bit in front of the start of laparoscopy. If you all remember that, the French gynecologist Moreau described the first or performed the first laparoscopic cholecystectomy in 1987. And so everybody was jumping on that with a lot of criticism by the general surgeons. But then I remember I was in Groningen and I asked, why I would not start that, exciting access as well. And I do remember there was 3 months that I arrived there. And in the night, there was a patient admitted who had a gastric ulcer perforation. And I said to myself, I learned a bit already skills by the laparoscopic cholecystectomy, why I would not do that. Although I was 3 months there as I would say, fresh surgeon, not in the staff, I said, I'm going to try to do that laparoscopically. I did it quite well. In terms, it was not so difficult, putting 3 stitches, but at that time, it was not easy. I remember 1992, we may not forget that. And at the morning, when there was a big staff, I think it was 50 people, university setting, I had to then explain the case that I did. There was criticism all over the place, but happily, I visited the patient at early stage before the stuff, and I could see that the patient was brushing his teeth. So he was already quite well recuperated. I said to myself, how is that possible? Because we all did it by laparotomy. Yeah. And then, although there was such a criticism and negativism, because Groningen is a quite conservative block, I would say, but I invited the most important members of the staff to join me and to go visit the patient. I think around 8 followed me. They have seen the patient, he stopped brushing his teeth, but they were sitting quite well, reading a newspaper, and my career was made there, by way of speaking. Sometimes you have to be lucky. And then I've given all the credits to start the laparoscopic access there on all different levels. Laparoscopic herniaplasties I did laparoscopic adenopathy for prostatic evaluation. The first laparoscopic colostomy, I did the reversal of a Hartmann, you know, difficult
Yeah,
operation.
I
I
did.
did it in 1994.
Yeah.
And so I was quite well, you know, I would say both in front of open surgery, because I was trained in open surgery. That was the lucky, but I was in the front of that new and exciting access, which is called the laparoscopy, keyhole surgery. And so when I came back here in Bruges in 1994, although I could stay in Groningen, you know, they begged me to stay there. But anyway, I was willing to go back to my home country, my wife as well. I started then in Bruges, but I had an important advantage because all my colleagues who were very strong and good surgeons, but all did it by open access. So I started here the laparoscopic, listen, I started here the laparoscopic splenectomy, not an easy procedure. Some hematologic disorders like spherocytosis with a big spleen, not easy. It was all in 1995, 1996, etc. So I was more, I would say, focused in doing all those procedures laparoscopically. And then I jumped into oncological surgery. So I did laparoscopic colorectal surgery also for cancer, early stage. I mean, 1997, 1998, 1999, not evident. And I was not interested in bariatric surgery. And my colleague was at that moment, Dr. Van Rotte, a relatively strong surgeon in open bariatric surgery. Also, one of the earliest. I was doing the Scopinaro BPD 1997, you know, relatively early. He jumped into the laparoscopic band operation, I think in the year 2000, still a bit, you know, in front years. And then also he did the open, and that was my, I would say, access to go for the bariatric surgery. He did the open Mason gastroplasty. You know, that Mason described it 1979, 1980. After he started the gastric bypass, 1966, 1967, but the result of his bypass were not so perfect, you know, because it was a horizontal bypass, quite a lot of marginal ulcers, quite a lot of leaks. So we jumped into the VBG. And so his name, although he started a bypass as well, his name is more, I would say, accredited or related to the VBG, but in fact, he also invented the bypass. But anyway, so my colleague was doing the VBG by open access, and I was saying to myself, why I would not try to do that laparoscopically.
Yeah.
As McLean described it in 1997, I think, doing it laparoscopically, I designed an own clamp to do the gastrotomy at 8 centimeters of the esophagogastric junction, grabbing a big tube there, making with a circular stapler from the right side your gastrotomy, and stapling up nicely. Different than in the Mason, where there was a non-separation of the staple lines, quite a lot of gastric visual, of course. That was the Mason gastroplasty. And so that was, I think, 1998 somewhere. And I said to myself, Jesus, you know, that's nice to do so. And so by doing that, immediately you could see that the recuperation of the patient was so much more enhanced that patients were willing to come to me. And so in the early years of 2000, we started with the band as well. I said to myself, I was getting so many patients by just that laparoscopic access and the good results of the VBG. We may not forget, I think now Egypt is the solely country where they still perform what is called the butterfly technique, but it has been abandoned. But so many patients have operated for now 20 years ago, are still doing fairly well in terms of weight loss. But we all know what have been the problems of the VBG. It's called the gastric outlet obstruction, because the ring that we placed was too narrow from size. It was 5.8, it was 6.0, it was 6.2 centimeters of circumference, causing a bit of problems. But it was initially a good procedure. And then meanwhile, my colleague, if I just may continue it, Imran, if it's not bothering, no?
No, sir. Excellent. Yeah, please, sir.
No. And then my colleague, Dr. Van Lotte, started doing the open bypass in 1996 already. It was the Capella bypass, Rafael Capella. You're probably aware of that. It is still one of the best bypasses. It was a very tiny, relatively long pouch, which was banded, unhappily 5.5 centimeters of circumference. Rafael Capella is from New York, you know, did fantastic good procedure. And so my colleague was doing that open. And then I said, I'm not going to try to do that laparoscopically. You have Alan Whitgrove, 1993. You have Hans Lerner, 1996. But I was a bit late. I started in 2003. But we have learned from the open gastric bypass that so many patients developed a subcutaneous infection, had to be drained. Patients had to stay between 7 to 10 days in the hospital. Could you believe that? Just 20 years ago, so 20, 25
Yeah.
years ago.
Yeah.
And then I did the first laparoscopic gastric bypass. It was, I think, initially retrocolic, retrogastric, yes, according to Whitgrove in 2003. And then quickly I swifted for the Learnrod technique, which was anticolic, antigastric. And so all the operations and the anastomosis have been done in the supramesocolic region.
Yeah.
That's why I think it was in 2004. And then I adopted also the technique from the linear anastomosis to the circular one. That's another story. But doing that gastric bypass by laparoscopy, we didn't have the disadvantage of the VBG or the band. What was that? A relatively poor quality of life. Patients could not eat quite well. And then suddenly with the bypass, they could eat quite well, had a good quality of life. And at the same time, the weight loss was even better than in the case of a VBG, a band, or a pure restrictive procedure. So that was, I would say, a bit my success and my luck as well, because of my laparoscopic training skills that I developed, a bit, the drive to jump on that. And suddenly, so many patients came, and then at a certain moment, already in 2005, had to decide to take 2 colleagues additionally. I abandoned, which was not an easy step for myself. Also, my father was the dean of the University of Liver. Said, "Are you really gonna lose or gonna, abandon the oncologic surgery in favor for that, so-called, obesity, more or less self-inflicted disease? Are there not other priorities?" But I said, it's a serious disease. I'm going to take care of that. And the good thing is, once you operate somebody quite well in obesity surgery, that's a bit the business, but suddenly, they tell it to the family. Some of those family members are obese as well. And before you know it, you have so many, plenty of patients. And that was first of all, my laparoscopic access that I've trained quite early in the stage, and then jumping into the bariatric surgery, doing it laparoscopically as well with success. That was a bit a short summary of what I would say. I have to be humble, a bit success that I developed. So I've been mainly lucky, but I worked hard, to achieve that. And meanwhile, I think we did around 18,000 bypasses, which I think is a fairly good number. Yeah.
Oh my God, sir, really, it's great honor. And also your participation for the growing, and also now that we see bariatric surgery, definitely you are one of them who are pioneer of bariatric surgery. And in my opinion, tonight our session will be one of the best. Sir, we have divided these questions in 3 parts. Some questions are pre-operative or patient selection, and then we will talk a little about technical points, and at the end we will talk about post-op. Sir, according to now, in my opinion, Professor Bruno Dillemans himself is a guideline. Sir, according to your opinion, what is a relative and absolute contraindication of Runway gastric bypass?
I think, and I've learned a bit in that course of my, I would say, career, that now I have really some absolute contraindication for the bypass. Although it's important to mention you that as a disclosure mix of my procedure, I think that for the primary procedure, 70% are still the classical wide gastric bypass. 25% are going to be sleeve or are actually sleeve gastrectomy, and 5% are OEGBs and other procedures, Santor, etc. But still, we favor here in Belgium, in our institution, in the Netherlands, Scandinavian countries, still the wide gastric bypass. But I've learned that there's some, what I think, absolute contraindications. One of those is Crohn's disease, which is relatively common here in our region. Certainly when the Crohn's disease is active, we will not willing to touch a small bowel barriers, because the sleeve gastrectomy is far the more safer operation, also in discussion with the gastroenterologist. The second one is in discussion with the endocrinologist, diabetes type 1, where we did quite a lot of bypass in the past. I abandoned that after discussion of the endocrinologist here in Belgium in general. I think a sleeve gastrectomy, even if they're reflex, we're going to do a Nissen sleeve. We don't do any bypass anymore for diabetes type 1, because the control of the sugar levels and the risk to have any ketoacidosis is going to be probably a bit higher if you go for gastric bypass. That is important. Advanced liver disease, I think that is evident. We don't do that neither. But also patients with, I would say, a pre-renal stage disease that they have to jump into a kidney transplant. We have also here a quite big nephrology team. When they send me patients who have end-stage renal disease, you know, and who have to have a CPD or hemodialysis, we don't go for a bypass. They have to take also those medications. So also for those cases, we go for sleeve gastrectomy. If there's reflux, we're going to put an insulin on top of that or a toupee. So those are more or less absolute contraindications. On the other hand, you have the relative contraindications. Patients who got a lot of laparotomies. Now, if the laparotomies have been done in the pelvic region, we always say to our patients, and when we decide, like for diabetes, I'm convinced that, you know, a bypass is better than a sleeve, discussion OAGB or whatever, then we opt, you know, to go for the bypass, but we say to our patients, they have to write it down, the agreement upon that. If it would be too difficult, we're going to go for sleeve gastrectomy, and we're not to go anymore for laparotomy with all those disadvantages. Then those are a bit the instances. But for all other cases, in fact, there are no real contraindications. For sleeve gastrectomy, it's a bit the opposite. When there is reflux at stage, really, GERD B, C, D, you know, and you cannot go for bypass. Those are the only cases that we still go for sleeve, but you're going to wrap, like David Nock has described, we're going to do an initial sleeve gastrectomy. That's a bit the reality. That's a bit more or less, I would say, or formal and contraindications, or I would say relatively contraindications in case of laparotomy incisions that have been made.
Sir, excellent, sir. First time I hear about type 1 and also Runway. Have you experienced any case that patient after Runway gastric bypass suffer with ketoacidosis, DK?
Yeah, we had one. So it's interesting to see. We had a nice paper in Diabetes Care in 2015 with my colleague from the University of Leuven and from Ghent, where I was the only guy doing gastric bypasses. And I think I brought in, what was it, 12 patients. I'm going to say 11 of those patients were doing fairly well. Although we all know when you go for diabetes type 1, you know, you cannot really change the disease. And I always say where, you know, if we operate diabetes type 2, it's real metabolically aimed to get a better control. When you operate somebody with diabetes type 1, you're not aiming to have a better metabolic control. You're going to purely back again, go to bariatric surgery. That means losing weight and having secondary prevention. That is right. But you're not going to alter the hemoglobin A1C. You could, you know, go down in the insulin dose of, let's say, 3-fold or 4-fold, but you're not going to alter the disease. The only thing is when patients are eating a bypass, certainly when it's a quick anastomosis or high anastomosis, you have such a sudden postprandial glycemic dyscontrol, which you're never going to have in a sleeve gastrectomy because the pylorus is there. So it's quite evident. And so one patient, a young patient, male patient, developed quite a lot of patients problems. So on those patients, I have to do an undo bypass because it was an uncontrollable, I would say, for the endocrinologist, manageable disease of diabetes type 1. So we discussed also, we're not going to go for any gastric bypass anymore for diabetes type 1. At least this is a bit our conviction.
Yeah, excellent, sir. Sir, regarding smokers, what is your opinion?
Smokers, I have to say, I've heard a bit who he was, and you also, I mean, smokers, we really ask to our patient, you have to stop smoking. And what they say and what they do is a major difference. When they come to us, you know, you really have to stop. You even can do control. We send them sometimes to the pulmonologist who is a tabacolog, you know, taking care of that. But patients can do that temporarily. You understand what I mean? You operate them, and after 6 months or a year, they're back again smoking. So they all are so convinced and having to willing to have the operation that they can stop quit smoking. And we ask sometimes for 3 months, but later stage, I have no any statistics around that. But sometimes we see patients back after 1 year, back, oh, you're smoking again, you see?
Yeah.
So, I mean, it's not an absolute contraindication. What is smoking? Look, you have 5 cigarettes, you have 30 cigarettes, you have cigarillos. It is not easy, but we really stress on our patients to stop, to quit smoking definitively. But the control on that, that is not easy. That is not easy.
Yeah.
So it's not a formal contraindication. No.
Sir, one of the concern after any type of bypass and also Runway gastric bypass is micronutrient deficiency and also as well as calcium deficiency in a patient after menopause, a female patient with symptomatic osteoporosis. What is your protocol?
You were saying a mini bypass, huh?
No, Runway gastric bypass.
Now I'm going to say I was just mentioning 18,000 of what I would say proximal type of bypass that we did, say 50 millimeters of BP limb. Really, if you really carefully look to the literature, and we always give vitamin D, we also give calcium supplements. I am not aware, even in older female patients, to have a big problem of osteoporosis. I think it's a bit clinical overestimate. You know that when somebody loses weight, is also mobilizing calcium from the bones. You understand? So if you do your densitometry afterwards, it's a false examination. Why? Because suddenly you're going to see there's a bit more osteoporosis. Why is that? Because it's much less heavy. Somebody is much more heavy, is concentrating bone. Why? When you're going to see somebody with hypocalcemia, that is an important thing, you know, that is to be careful. We never see that. So I think that osteoporosis is more related to the loss of weight. And indeed, if you're going to start doing OAGBs, if you talk about, you know, BPDs and do it in a switcher, that's a different story. But you cannot compare that with the proximal bypass, you know. I don't have really any data, but patients are coming to us sent by the physiotherapist 10 years after gastric bypass. It's different than after BPD. We have seen disaster stories, complete true. But after proximal bypass, with 50 centimeters of BP, no, we don't see a big problem.
Sir,
I think it's a bit overestimated.
Sir,
you can do, yeah, that is my opinion.
Definite, sir. In a technical options, we will talk about BP limb. And
what I just may mention to you, Imran, is that you have to do parathormone control of that. You're going to be amazed to see if you compare parathormone, you know, after distal bypass, where you lengthen BP limb, and after proximal bypass of 50 centimeters BP, you nearly see any big difference. That big problems on the proximal type of gastric bypass, because the absorption at calcium is not a big issue. Vitamin D, 80%. And certainly your countries have that deficiency. So you easily can correct it, I think.
So just imagine a patient that after menopause with the symptomatic osteoporosis with high PTH. So what will you do?
Yeah, we said, I said them, if I may say that, to our colleagues from internal medicine. I'm on that part a bit. We have a good team, but you have to start with, I think, high doses of calcium and together with vitamin D. And that, I think, is the classic treatment of that. But back again, if I would see one patient on yearly basis, I don't see that. If they test patients with BPD, we still see them, of duodenal switches, very rarely done. Then we send them always to the endocrinologist and the physiotherapist, and they're going to take care of that with all the medications they have.
No,
so
sir, my question before surgery, just imagine this is a case, a 60 years old female.
It's not a contraindication. It is not a contraindication.
Yeah, just this is my
before. No. It's not going to alter, I think, the issue of osteoporosis. No. And I'm going to say it's interesting to mention that otherwise you would go for sleeve gastrectomy systematically for all the patients. But the results of a sleeve gastrectomy, if you look to the literature, certainly those patients who are a bit more invalidating are not so good in terms of weight loss. It's different whether you're going to be your endpoints. And you don't have to accept to have 30% of total weight loss, but 15% or 20%, if it's not, that's not good enough, you understand. So for elderly, fragile patients who are not very good mobile, I have a bit the impression, although we do sometimes sleeve gastrectomy because it's lesser invasive on that term, we may say that the results are a bit less than if you go for that classic proximal bypass, but with a normal BP.
Yeah, normal BP. Sir, regarding age limitation, have you any age limitation for you and my adolescents or older age?
No. We have operated patients with bypass and sleeve at the age of 80 years old. I'm not proud to say, but patients are coming to you at consultation back again. And the most of the issues we say to the patient, it's not to gaining further length of years. That's stupid, It's just in regarding have a better quality of life. And most of those patients, very obese patients, are so disabled, they are coming with a wheelchair, that I think the weight that you try to achieve is to getting them a further better quality of life. And I think the upper limit that I think is 80 years or 81 years old, I think. But in the decision to go for sleeve or bypass, sometimes I would even opt to go for an OAGB because it's technically a bit easier, certainly for the very obese group of patients, but just taking 1 meter 50 then. But it's not a formal contraindications. That not.
Sir,
And
sir,
here in Belgium, we have also reimbursement since 2010 that we also may operate patients with an age which had exceeded 65 years old. Where in quite a lot of countries, I think the upper age limit is 65. It's not in our country.
sir, excellent. Sir, regarding pre-op endoscopy and H. pylori eradication, what is your protocol?
Yeah. Our protocol was very tough many years ago because we were so afraid that for the marginal ulcers, as you know, like for the marginal ulcers in the time we were not using PPI, I refer to 1997, 1998, we did a study and we at those stages at the early years of the Capella, we had 4.9% of marginal ulcer, but the patients were just put postoperatively on 2 weeks ranitidine. You remember that 300 milligrams a day.
Yeah.
And they all developed an ulcer 6 weeks or until 3 months later, 4.9%, which is 5%. And then we have say, you know, we did all Helicobacter pylori testing at that stage. And we looked at the literature also in the early 2000s. There was seemingly not a fantastic good relationship. The relationship was much stronger with smoking or not smoking, with anti-inflammatory medication or not, with cortisone as well. Don't forget cortisone or not, that we say. And then the PPIs were coming in. And since we have started with the PPIs, and that's now very important, with the start of the PPIs, giving not for 1 month after operation, for 3 months after operation, because most ulcers develop the first 3 months. So I've heard, I had a Spanish surgeon visiting me 2 weeks ago. I said, you know, we see so many ulcers, you know, at 6 weeks, but they stop the PPIs at 4 weeks. That's too early. That's my conviction. You have to give it 3 months. And for smokers, if they could not quit or they have restarted, anti-inflammatory medication for, you know, cardiac protection. So many aspirins have been given. We give that lifelong. I think that's very important. But for the Helicobacter, we all did the testing later. And in our countries, I think the prevalence is, what is it, 25% or so. If you go more to the south, because I operate a lot from Turkish origin, I think it's 60% when we did the testing. We eradicated, but there is not, because the ulcer incidence now is less than 1% we see in a group of patients. So, and if we do then for those ulcers, really refractory ulcers, difficult to treat ulcers, 100% correct. We do the testing, I think if 50% is present, where in the literature it's around 30%, then we eradicate it. But there's not a clear clear relationship between the presence of the Helicobacter pylori and the eradication that you give and the prevention or the not prevention of the ulcer afterwards. It's so acid related, like Hedberg have shown in 2005, that is the most preventive factor, get the acid away. And that's one of the things that we went a bit higher with our gastric pouch creation because too many parietal cells have been left with the classic Capella, which was 8 centimeters, you understand? So it's better to make your anastomosis a bit higher to leave a bit less parietal cells. But our incidence is now, I think, less than 1%. And all are that when it happens, you know, after years, they restart smoking, a bit marginal, socially spoken persons you see, not well treated. But with the PPIs that have really, I think, you know, had such an important impact in the prevalence of marginal ulcers that we see.
Sir, according to your opinion, so H. pylori has no relation to marginal ulcer.
Not an important.
Yeah, and we eradicate, we always prefer to eradicate. And one of the reason is maybe after, so maybe peptic ulcer in remnant, or why we eradicate H. pylori?
Yeah, an important reason also for cancers. That is one of the reasons that has to be eradicated.
Yeah.
But the incidence of gastric cancer worldwide, and if you look to the papers, experimental studies of the Runway and the gastric cancer evolution, both in the remnant stomach or in the gastric pouch, is less than in the normal population. Less. And the reason is that, you know, that I would say causative agents coming from the food, like salts, are not coming to your stomach anymore. So that could be not a good objective reason. And the incidence, very good that you mentioned you. I think we had 2 patients who developed a peptic ulcer in the remnant stomach. 2 patients of that. But it's also a very rare phenomenon because it's also gastro-related. It's also related with the food which is coming to your stomach. So I'm so amazed that it's so low incidence of a peptic ulcer in the remnant stomach after gastric bypass. It's amazing. And now we don't systematically eradicate Helicobacter pylori anymore, you understand? So, and we don't see that higher incidence of the peptic ulcers at the remnant stomach and also not at the gastrojejunal stomy. So
Sure.
for me, that relationship, not only, it's all in Belgium here. I'm not going to say some centers do that systematically, or incidence is also not as in your countries. If you are in Turkey, you have an incidence of 70%. Also, the southern countries have a much higher prevalence of Helicobacter pylori.
Sir, in such a case that is a H. pylori positive, have you any follow-up after surgery, after 1 year, 6 months, after 2 years? So again, you must check the H. pylori, or no need to check such a case?
No, we check that. We check that for those cases for sure. And it's then checked by our gastroenterologist. We leave that to the gastroenterologist. On that part, I mean, I can outsource those things. It's all have been followed by a gastroenterologist. But so they are eradicated. But you know that the eradication process is not always 100% successful. So then we do a briefing test, because patients back again endoscopy, you know, it's not always easy. We do briefing test after the eradication process. And if they are not eradicated, you know, or gastroenterologist giving additional antibiotics, you know, but most of them are with the classic program eradicated. But after that, you know, they are still followed. That is true.
Thank you. Sir, now we will talk a little about technical points and technical questions. Every surgeon during his life, so definitely there's some evolution. And now I am talking with someone who is pioneer of Runway gastric bypass, one of the pioneer of Runway gastric bypass. Can you, sir, highlight those important points like length of pouch, that diameter of gastrojejunostomy, like that you are using now, this which type of stapler? So we are interested to hear this journey.
So as I said, you know, we started with the open gastric bypass, the capella, and it was always a hand-sewn anastomosis. We were keen on that. It was quite well accessible because it was around 8 centimeters, and it was nicely done in one layer. Then we did laparoscopically, not hand-sewn. It was done the early, I think, 10 operations I did with a linear cartridge, as most of the surgeons, I think, you know, but I was not very keen, because I always say, and we can discuss hours about that, with your linear staple on the back side, 2 centimeters, 3 centimeters, you always have to be careful where's the other staple line of your vertical transection. So I was not always keen that the distance between those two staple lines was wide enough, you understand? So I said to myself, is there not a better method? And then with the circular staples, we had the results, you know, that have been published with 1.2. I said, we're gonna start doing that with the circular staple device already in 2004. So I just did 10 with a linear cartridge. And I have to say it was quite successful in terms of technical feasibility and easiness, and also safety. We always take the lateral corner of the gastric pouch construction. We always do that on the standardized way. So that part I didn't change a lot, but you know, it's the 2.5. So it is relatively wide in terms of anastomosis, you know, not too small as Michel Suter and other very famous surgeons are doing. It has to be a bit wider to prevent stricture, as we all know, but also to prevent leaks, that at least the donuts that will be entrapped in your circular staple are going to be strong. If you make it too narrow, sometimes the donuts are not completely intact. So take a 2.5, and the anastomosis is relatively safely made. On the lateral border, there's always a good vascularity in front side as back side. I cannot show it here now, but most surgeons that visit me know that quite well. But we don't do the oval method. You know, the oval method, you know, when you go from inside to make then the circular staple device, bring it in. I think it's too traumatic. At least it is potentially too traumatic for the oropharynx. Yeah. And I was just referring to the Spanish surgeon who visited me 2 years ago from Barcelona, quite famous surgeon. I'm not going to mention his name. He's doing the oval method. And he was mentioning to me that he has seen so many wound infections there, because anyway, the pistol of the circular staple has to be brought in from extra-abdominally. He has seen so many wound infections. And when they did the culture of that, it was all bacteria coming from the oropharynx. I was amazed from that. So when you do that, as we do, transabdominally, and you still have to open the stomach because of the acid, you know, those bacteria are absent, by way of speaking. Yeah. So it's a safer anesthesia you're going to make, that the bacterial content, I would say, the bacterial contamination of your incision on the left side is going to be substantially less, because we very rarely see any wound infection on that part. So that's just making the gastrojejunostomy. We didn't change, we didn't alter the method as we do that. What we changed accordingly a bit later on is the length of the BP limb. That is interesting, because based on the literature, we all know that that for the super obese group of patients, BMI of more than 50, super BMI of more than 60, the classic gastric bypass, with the 50 centimeters is not enough. We have learned that also a bit from the OAGB. We lengthened it down with 1 meter 50 or even with 2 meters. The most ideal situation, which I not always do systematically, I have to say very fairly, is that you count the total length. We all know that, because the variation is important from 4 meters to 11 meters with an average of 6 meters. But we know based on the literature that you safely can go for 1 meter 50, and at least you're going to enhance a bit the results of the achievement of your weight loss, as I really think that the OAGB results in terms of weight loss and diabetic control are indeed a bit better from the classical white gastric bypass. So for those group of patients, we're going to lengthen a bit the BP limb. On the other hand, and that's interesting, I think we would stress to that, Imran, we all think that the bypass works by restriction, by malabsorption, and by hormonal effect. You know that in nice studies from Ostril, 2010, published in the American Clinical Nutrition, Journal of Clinical Nutrition, Ostril from Dallas did a nice study where he looked to the netto energy intake, which was related either to the restrictive part of the bypass, either to the malabsorptive part. And what you could imagine that after 1 year, 90% of the loss of energy intake was attributed to the restrictive part of the operation. Just 10% was related to the so-called malabsorptive part, which is then Michel Gagnier saying the hypoabsorptive part. But anyway, just 10%. And why is that? Because still 90% of the sweets are absorbed in the alimentary limb. So if you really think like Broly was lengthening the alimentary limb, still some surgeon monarchs in your country did a nice study after 3 years with a very, very long alimentary limb. So it is slightly different in terms of favorite of weight loss in comparison with the classic limb. So the alimentary limb, there's still a lot of absorption in that part. You have to work on the BP limb. But what we try to achieve now is to enhance the restrictive part of operation on the longer term, because after 1 year, the SOS study also have shown weight gain afterwards. What we try to achieve now is a better consolidation of the restrictive part by putting a non-adjustable band on top of that. Has been described by Luc Lemmers, has been described by Mohit Bandari, has now also been described for sleeve. We do that for certainly young patients with a BMI that are more than 45. We say to them that it's better to put a non-adjustable band, a minimizer, a mid-collar, whatever, with 4 different standings, 8 centimeters, 7.5, 7 and 6.5, to put it around, not to tighten it, but no, it's just to prevent that dilation would happen. And the results, if you look at those that have been published, show good results. And so we try to enhance a bit more on the restrictive part in the preservation of the weight loss that have been achieved. To have better weight loss after 1 year, we work on lengthening the BP limb. Also for diabetes, I think it's better.
Sir, again,
but technically spoken, I didn't change a lot. Only when we did the GG anastomosis, it was systematically done with 6 centimeters. Now we go to 4.5 centimeters. Why? To prevent a bit intussusceptions, and also the closure of that ostomy, the jejunostomy, we always did it classically with a stapling device. Now we do that with a barbed stitch. And the good thing is that you don't close it longitudinally. Now you can close it transversely, giving even less chance that there would be any subobstruction or kinking at the entrance of the alimentary limb into your anastomosis. So we do that now manually since 3 years. The closure of the internal hernias, we have started to do that systematically at the end of 2012. Although I know that quite a lot of surgeons throughout the world, Rosenthal, etc., good friends of me, are still convicted not to do so. I think if you look to the nice papers from Sternberg in the Lancet, everybody knows that paper, from Sweden, where you see that you really have to close the internal hernia defects to prevent having that problem afterwards. That is clear. Just some things that we have changed in due course of a practice.
Sir, excellent. Sir, regarding this band, so again, it will be another issue, then erosion and same thing that we see in band.
No. What is the difference? Back again, what we have seen with the VBG or the banded bypass according to Capello of Melphobi, with the Gabe pairing, you remember that was just one size. You're just going to bring that device loose around your gastric pouch. It's the only thing is that you're going to prevent, that dilation would happen. And after some years, it could happen. But what we do for the bypass, and interesting, I unhappily cannot show that, we don't fix the ring on the stomach pouch, because with the stitch on the side wings of the ring, you put it on the gastric pouch, that could be a spot of erosion. That's right. What we use is we're going to use the remnant stomach to fix the band on the gastric pouch. The band is completely loose around it, but we're going to use the remnant stomach to fix it on the gastric pouch above and underneath the band. So if an erosion would happen, it's less likely because you don't fix the ring on the pouch. If an erosion would happen, you easily can retrieve it endolumely. Where if you fix the ring externally with a non-resorbable stitch, it's going to be very difficult to and tedious to remove that endolumely, because the fixation can be done on the external side. But I think the rings now have a diameter of 8 centimeters, circumference of 8 centimeters, completely different than in the ages where the rings were too narrow. So you cannot compare that.
Sir, how long time you are using this banded?
Since 2016. According to the IFSO Congress, if you remember that in Vienna, there was a complete session which was dedicated to banding those bypasses and even sleeves. Melfobi was running that session. I was moderator. And then the first papers from Luc Clemens, Mohit Bandari were coming in. And I have to say, I was a bit convinced, based on the fact that the old Capella bypass, as we did in the 90s, also had very favorable weight loss results, although quite a lot developed gastric outlet obstruction.
Sir, now how many cases you did with this? About how many cases?
I think with a banded bypass, I think 500 or something, 500.
500. If you compare with some cases, those are same BP limb, same situation, without
better maintenance of weight loss, without any discussion. I see that.
Yes.
And not only important, not more acid reflux. I was a bit afraid because we put that band around 3 centimeters from the esophagogastric junction. If it would be a bit too compressive, you could, cause not only acid reflux, but even passage problem. We have not seen that problem yet. Okay. And back again, the reason is that we put it loose around it. I'm not interested to have better results after 1 year. That's not the opposite. Then you work by lengthening the BP limb. That's a different issue. It's just the preservation, as we all know. When we have bypass after 10 years, the pouch is like this. The gastric junctions is like that. That means it's all dilate. At least you're going to prevent the dilation.
Sir, regarding these 500 cases, have you removed any band in these cases?
I think it's good. 3 in total. That's all. 3 in total, I think. 3 in total.
And now with this banded Runway gastric bypass, what is your standard BP limb for all your patients initial?
So the standard BP limb is always 50, as I said, certainly for the younger patient, because then I'm a bit afraid, for the malnutrition, if you go systematically for 1 meter 50 of a young female patient, like I don't gonna blame that the OAGB surgeon doing, for someone who's 20 years old, they go systematically for 1 meter 50. I think it's a bit too invasive. Don't forget that iron is absorbed by the duodenum and the proximal jejunum. In the study from Dr. Lee, V.G. Lee, when he compares the Runway with the OAGB, what was one of the most striking phenomena, that was the anemia, which was so much more prevalent after OAGB than after the Runway gastric bypass. Nobody mentioned that. But if you're going to systematically take 1 meter 50 for somebody who's 20 years old, after willing to have babies, etc., I'm still a bit reluctant. We work more on the length of the BPD, certainly for elderly patients. That is not an issue, I think. And then we work certainly for BMI 45 or 50. We take that 1 meter 50. Not that systematically 2 meters anymore, since the Omega study, you are aware of that, published in the Lancet, the French study, which was one of the reasons now that in France, the OAGB is not accepted anymore. Could you believe that? Yeah. So, and then if you look to the study of Mawar, did also a nice study, he also described that still the favorite length is 2 meters, but in practice, most of the OAGB surgeons are a bit more careful and went back again to 1 meter 50.
Sir, this is really very interesting. Now, in your practice, if a case routinely, this is my question for your routine cases, patient is same and you prefer banded Runway gastric bypass, this is your routine practice. That I understand.
No. From a BMI of more than 45. We don't do that for BMI 35 to 45. That's a bit arbitrarily, you understand? They have to be more obese because the results of the weight loss, as you described for the bypass, are less optimal for the super and the super obese group of patients. So we're going to try to enhance results more for the obese group of patients. Certainly above 50, we do that systematically. Before 45 and 50, we have to ask it to the patient because unhappily, it's also costs some money, which is still not covered by the government. It costs around 600 euros. So if patients are not willing or cannot pay, I cannot force it. But we offer that to a patient, not for patients between 35 and 45, still not systematically.
Yeah. Sir, regarding this BP limb, because that is, I think maybe we will discuss more and more in till next decade, we will also talk about the BP limb. And maybe we cannot standardize the BP limb. The main reason is different ethnicities, different dietary habits. So when I will talk in Dubai, different in South Asia, that is different in Africa. So definitely we cannot standardize at the globe. But so what is my question in the region that you are practicing? So have you, I understand, so you have different BMI, but again, in a case, just imagine with age 50, BMI is also 50 plus. Are you interested to increase BP limit in 100, 120 for better results?
Yeah, for sure. We systematically take down 1 meter 50. And even in the most ideal world, it would be better to count the total limit, because if you have somebody, let's say of 8 meters, then it's better that you even enhance that result. As we do with the Sugarman type of distalization, you're aware of that for an unsuccessful result after bypass, we always systematically count. But still, it's not a common practice that we count it for primary procedures. If you look to the literature, very few surgeons are doing that. But the most ideal world, you could imagine that you have someone of 10 meters of length of small bowel. If you're going to just take 1 meter 50, it's not also the ideal length. You can't go much further away. But we don't do that in our practice systematically. I'm already pleased to take 1 meter 50 by way of speaking, based a bit on the results of the OAGB.
Then, sir, your elementary limb 70?
1 meter.
100, yeah. And then it's good. So regarding hiatal hernia, so if you diagnose hiatal hernia, large size before surgery, what's your protocol?
We do the bypass. The bypass is without any discussion the best. And we try to do a nice reposition of the pouch. We do a cruroplasty, and then we use the remnant stomach with 1 stitch. We grab the remnant stomach, grab the left crura, and fix it on the pouch as well to get it fixed there. I think it's a good plan.
And it will be like
No, toupet, that's a modified niche. No, we're not wrapping it up. You just use the remnant stomach with 1 non-resorbable stitch, an 80 bond. You grab the stomach is there, the native stomach is there just in front of you. You grab it, because otherwise we all know that, and you have to be careful for the recurrence of the gastric pouch re-herniated back again in the chest. Yes or no? We all know that. So in trying to fix that, some surgeons are fixing the jejunum to the remnant stomach, but that doesn't do a lot. What you have to do, you use the remnant stomach with 1 stitch, you take a big bite on that, you take the left crutch, which you close to the right crutch, you grab it there, and you grab it on the posterior side of your staple line, you grab the pouch as well. Safely done, and then it will remain there. That's the best way. Kelvin Higa is doing that as well, Kelvin. So yeah.
Excellent, sir, excellent. So you have mentioned regarding closing your defect since 2014. After 2000,
the major defects, not the hernia, the internal hernia defect.
No, I am talking about this closing defects of like Peterson and JJ.
At the end of 2012, we started.
Well, okay. So after that, have you faced any internal hernia?
Still, without any discussion. Yes. That would be a fairy tale that you don't see any internal hernias later on. And the reason is very simple. You still have to leave certainly for the Patterson, you still have to leave an opening. You understand? You have the colon there. We try to fix it as high as we can, but you cannot completely close that. And some of the sutures that we do, and that's the problem with an interrupted, a running suture or a bursting suture. sometimes you're wrapping up a bit the tissues. So the anastomosis of the GG goes a bit down, etc. So that's the reason that we do now with locking stitches. When we do it with the V-lock, locking stitches, that you're not wrapping up, because otherwise anastomosis go down. It's not nicely neither. The only thing is that we now regularly use as well our clips, our staples, as Gislason described. Probably you're aware of that. You are nicely stapling devices to grab it. And the good thing is that you can keep the peritoneum on the same side. It has been criticized when I have to do live surgery. I don't do that anymore with stapling because it's criticized. But Gislason described it on more than 5,000 patients with fairly good results and recurrence, let's say not recurrence, internal hernia incidence of 1% later on. Gislason from the Nordic states. And it's ergonomically so much more easy to do that with it's a hernia stapling device. You have not seen it, the EMS from the past, and now a classic hernia. Surgery visited, and you are grabbing the blood vessels less, because you know with the stitch, sometimes you're grabbing one of the vascularity things and suddenly whoop. But anyway, I mean, we always try to do that also by a barbed stitch, which is holding very well, but not wrapping up too much. We use interlocking stitches as well, that at least, you know, the anastomosis don't go too down. And otherwise, if you close it too firmly, you got more tension on your gastrojejunectomy. You're certainly aware of that as well, so you have to be careful. Only cases where there is really quite a lot of tension, traction on your gastrojejunectomy, and the patient is elderly, in those rare incidents, we don't close. We don't.
Okay, sir, excellent. Sir, regarding this JJ, you have highlighted. Now, what is your preference? That is end to side, that I understand, that is 4.5.
Side to side, side to side.
You are still side to side, but
yeah, side to side. Yeah,
it is side to side. And 4.5 and sir, excellent, sir. Sir, now we will talk about some post-op questions and also follow-up. So, have you any protocol post-op endoscopy of Runway gastric bypass?
No, not.
All in symptomatic patients.
Yeah, not necessary. No.
Not necessary.
But that's different with sleeve. Oh, that's a different story. But not for bypass. No. But whenever the patient has symptoms, you still, with the first symptom of a marginal ulcer, you know that it is not pain. What is the first symptom of a marginal ulcer? When the patient, after 3 or 4 years, saying, "Doctor, I can eat a bit less." Can eat a bit less. It's the inflammation around the ulcer which is giving the symptoms. So somebody thinks she has something. No. The first sign is not the pain. That's not the issue. Suddenly they say, "I can eat a bit less. My meat is not pulse." That's the first sign of an ulcer. Yeah.
Sir, excellent. Sir, regarding this marginal ulcer, you have mentioned now about 1% are your cases.
Yeah, not more than that.
And have you faced any intractable marginal ulcer?
Yeah, for sure. Yes.
What you did surgically for these cases?
With big forest, deep forest ulcers, grade 3 at 4, sent by the endoscopies. We give high dose PPIs. We give sucralfate, intensive treatment to 120 milligrams PPIs, which is very high, sucralfate. And we send them back again after 4 weeks. Still the ulcer is there, where you can see, some thread of some clips from the old part. And when it's not healing quite well, what we do then, there's only one good method, I think, is we furnish a new gastrojejunectomy. That's the only salvage. But we give all chance to optimize the medical treatment, but the success ratio is far from being 100%. If the patients are still symptomatic, have a very poor passage and pain, and endoscopy showing big again or back, still a big ulcer, there's no other way than either undoing the bypass. I don't think there's any need to do so. You're gonna create a new gastrojejunectomy with or without a vagotomy. That is another discussion.
Sir, regarding this weight regain, that is also another issue after Runway gastric bypass. And also we have question from Facebook, Dr. Ahmed, I think from Turkey. He's also asking about algorithm after weight regain. What's my question? So my question, sir, my question also, we will follow the question of Dr. Ahmed. And my question is about which percentage after your patient, after Runway gastric bypass, are suffering with weight regain, especially because now you have two criteria, low BMI, low BMI till BMI 45. That's not low BMI, but okay. And then morbid obese. For low BMI and young patient, you prefer banded Runway gastric bypass.
Primary, yeah, primary, yeah.
Primary. And for morbid obese, the BP limb is 150. Till 150 you prefer. Now, which percentage of your cases after this, all of this evolution, suffering with weight regain?
The patients that we see now are before we put the band in 2016 or lengthened the BP limb, but did in 2018, you know. But we see now patients, you know, having 18,000 patients done, and we are a referral center from all Belgium and the Netherlands to send over patients with weight gain after bypass. That is our specific main interest. We do around, you know, 4 to 5 revisions for bypass for weight gain on weekly basis. And what is our algorithm? Referring to the question of my Turkish colleague there, we published it 6 months ago. It's interesting to have a look for that in obesity surgery. We have, I think, a very fine algorithm for that. I think if somebody comes with weight gain, we have to say now non-responders, secondary non-responders. We may not use the word failed anymore. I think it's completely correct based on the IFSO and the AIS guidelines. So when patients have weight gain, we do the good investigation. What is that? An upper GI. Even CT tomography, as they do in Egypt, better. We don't have that tool. Upper GI, endoscopy, lab test. Now, for those cases where you really see that something wrong is in the patient, a gastric fistula, a big fundus of a secondary gastric bypass after a band where the surgeon was a bit too cautious. In those instances where you can see some anatomical reason, I would say aberrancy, then we straight away go for a corrective surgical procedure because there's a reason why the patient was not doing well. But the vast majority, around 90%, if you do the upper GI, if you do the endoscopy, you see a more or less normal bypass, normal liquid bypass, or a slightly dilated pouch or slightly dilated gastrojejunectomy, or a candy cane, it's a bit too long. Those group of patients, we put 3 months under compliance enhancement. If the patient, and it's not run by myself, it's run by the nutritionist and the psychologist, and after that they make a bilan, they make an anti-evaluation for go for surgical or not. For those patients who not show any compliance and do not lose weight, we don't go for an abdominal surgical procedure anymore. We know that also Kelvin Heger was saying that Michel Suter, if at a certain moment patients go back and is not willing to change his or her lifestyle, forget it. You understand what I mean? Good. But for those patients who do compliance, and then we go for laparoscopy, then it's important. Before that, we do a daily caloric measurement. So the patients have to write down for during 1 week everything what they eat and what they drink. They have to measure that. 120 grams of chicken, 60 grams of whatever potatoes. They write it down. Our dietitian is going to take 1 hour and 50 minutes to do that measurement. And at the end, we have an anti-evaluation. And what we see that patients sometimes are eating 1,200 kilocalories a day. And on the other hand, we have patients who are eating 3,000 kilocalories a day after an anatomically well-performed gastric bypass. So on that part, it's so important to have that compliance enhancement, if you understand what I mean. But for those patients where you say that, okay, you are fitting for surgical procedure because you had a positive evaluation 3 months after the start of the compliance, then we can go for a surgical procedure. If the patient has loss of restriction, as done by the measurement, then we're going to add restriction, which is the most logic. So why you have to work on distalization? Because back again, the patient have bypassed, they bypassed either by polyphagia, either by hyperphagia. We're going to work in adding restriction. And then during the operation, when we see that the gastric pouch has dilated, the gastrojejunectomy has dilated, the candy cane has dilated, we do a gastrojejunal sleeve, better gastrojejunal sleeve than just the gastric pouch result, and we're going to put the non-adjustable band on top of that back again with the aim of a primary bypass to enhance the restrictive part of the operation. But for those patients, that's interesting. That was the aim of our publication, where you go into the abdomen, you see that the pouch is quite normal, you fill it with air, and you see, how is that impossible now that this patient went? Those patients, there is no issue to trim the gastric pouch, to resize the gastric pouch, because there's no anatomical substrate for that. For those patients, we're going to put an adjustable band, the pars flaccida, and we use the remnant stomach to fix the band by putting the stitches above and underneath the band, using the remnant stomach and fix it on the pouch. We have reported our results in obesity surgery, and after 2 years, we had a additional excess weight loss of around 50%. Is that good? I think it's fairly good in those cases. But we had our complications, and I would certainly invite everybody to look to that paper, and also for one of our lectures, you certainly can, and you certainly can prevent those complications by some technical issues. It's now a bit too far-reaching to discuss that, but that is for those group of patients who have loss of restriction, and it's around 80% Ibrahim of the patients who have loss of restriction. For those 20% of the patients who are still quite well restrictive, eating 1,200 kilocalories a day, most of the time elderly ladies, a bit disabled ladies, they still do their best, but they still see weight gain. In those cases, we do distalization. Yeah. According to Sugarman, so you cut your alimentary limb before the anastomosis, re-implant it later, but instead of Sugarman and Rawlings described to leave 3 meters of total alimentary limb length, that's too less. You have to leave 4 meters. According to the publication of Giassi, Kelvin Higa, Eric De Maria, in SORT in 2018. Everybody has to know that. So they had a paper where 96 patients got the distalization according to Sugarman. In the 11 patients of the 96, they first were using 3 meters of absorption capacity. 1 meter is 50, let's say elementary, 1 meter is 50 common. Of those 11 patients, in 7, they had to proximalize with 1 meter because they had intractable diarrhea and hypoalbuminemia. So they changed the strategy, and the 85 consecutive patients have been treated by leaving 4 meters. And they did not see any of those serious complications anymore. So that is also a bit the advice that I would give for younger surgeons to go for distalization. Be conservative. That's also the advice in the publication of Giassi, because nutrition, the patient has to follow nutrition laboratory testing on a very regular basis, and still you not always have that under control, certainly when the patients are not compliant. So distalization looks to be, it's a relatively easy procedure, although the closure of the mesogap is not so easy, but making a new anastomosis is not a big issue, but the follow-up of the patient, I think, is critical. It's a critical issue.
Sir, excellent, excellent, sir. So a detailed, in my opinion, answer about the question. Just my question about resizing of this gastric pouch and resizing of this gastrojejunostomy. How you see the role of endoscopy?
Yeah, I think I looked at the papers very carefully. We all know Manuel Galvao Neto, fantastic endoscopic surgeon on the top of the world. The real name a bit is still Christopher Thompson from Harvard University. If you really carefully look to the papers, now a new paper that he published, what is the total weight loss after 5 years? You know that, Imran, what is the total weight loss? In the study of 330 patients, 8%. It's not bad, because you may assume that the patient otherwise would have even further weight gain, but 8%, is that fantastic? And what is the problem is in his study that he published, and it was a big study, 330 patients, that 39% of those patients had an additional treatment in that 8%, including pharmacotherapy, including giving, GLP-1 analog. So if it's attributed to the additional treatment that we're giving, all the patients have been put on a very stringent, intensive lifestyle modification group. So we don't know if it is really the endoluminal downsizing or the additional treatment that has been given to your patient. But I think still it is promising, but that was already 10 years ago. You understand what I mean? Meanwhile, they designed the StomaFix, which was the preluder of the Apollo overstitch. But see the results, they have been stopped. The firm is bankruptcy. So the results are promising, but it's still under the umbrella of promising, if you understand. Can you hear me?
Yeah, sir. Yes, definitely.
But I cannot see you now anymore. I'm sorry.
No, sir. Please continue. We can see you.
Okay, good. That's a pity that I cannot see you anymore. Is that okay? But anyway, I if you can see me, that anyway.
We can hear you, sir, and also we can see you.
Okay, good. It's a pity that I cannot see. Okay, but ask, no problem. I cannot see you. I don't know why. Okay, but you can certainly ask. I'm sorry.
No, it's okay.
No, it's not okay. I'm sorry. I just can't see. Did you?
No, maybe
it's 8 o'clock. It could have been stopped, or?
No, sir. Because this is unlimited.
Yeah.
There is no limitation.
Okay, wait a sec. I think I can open it again. 1 second. I'm
Yeah,
sorry.
you can click that
Yeah,
camera.
I'm there again.
Okay, okay. Sir, excellent, sir. Really, it's amazing. Sir, so because
I'm sorry that I speak so much, but it's from my heart. So,
no,
okay.
no, no, sir. No, it was a great experience, and that I predict before interview, this will be one of the best, and no doubt this was the one of the best. Sir, now after 18,000 Runway gastric bypass, so what is your main concern after Runway gastric bypass?
Main concern is still weight gain, not the complications that have been mentioned, like an internal hernia, intussusception. We all know that it's still weight gain. And I would say that the bypass is still on that part fantastic and magic, because it's still standing after 55 years. Could you believe that? Because we had the BPD, we had IKC, we had the band, we had the VBG. It's still there, and it's still the reference to other newer procedures that's going to be developed. On that part, it's fantastic. But I still a bit disappointed for my elderly bypasses 10 years ago, 15 years ago, that we hoped a bit that would be the final operation. And as I mentioned to you, it's still 20% have weight gain, because although you do a fantastic operation, still it's not the magic one. So that's still the commitment, the dedication, the incentive, the compliance with the patient still plays such a crucial role in the end result. The complication on itself, really, as we mentioned, marginal ulcer, we all know that they are manageable. That it's not a big issue, I would say, anymore. Although it has been criticized by the sleevers. If you have a bypass, oh, be careful, your life is going to be a misery. Also in your countries, like in Dubai, it's not to blame, but everybody of the patient, oh, the vitamins, have to take lifelong vitamins. That's completely overestimated on my practice. Really, that's not a big issue. The only issue is that still the maintenance of the weight loss and the follow-up is critical. When the patients are doing well, they don't come up from the follow-up. They say, why I have to go to the doctor? I'm feeling good. And then after 5 years, they go back, doctor, I have weight gain, but not 5 kilograms, they're 20 kilograms of weight gain. That is the problem. So we do good abdominal surgery, but we still don't do neurosurgery. And still, I'm afraid that some of our patients are getting fitted with a brain transplant, that they're actually having an abdominal operation. I say that frankly. You have such a patient as well. Yeah.
Yeah. Sir, maybe, so my main practice is OAGB and 60 to 70%. And it is great news for myself. Now, Professor Bruno also started OAGB. As you have mentioned your journey of bariatric surgery, you have started from DBG and then gastric bending, and also some part is sleeve, Runway, and now started OAGB. And in future, we will be more interested to hear more about OAGB from your side. Sir, how you predict Runway gastric bypass?
How you?
Prediction, future of Runway gastric bypass.
I think I'm going to be still stand there, right? Because what is one of the big issues, Imran, I remember I was in a debate in IFSO EC in Barcelona 2012. I was in a debate where they asked my opinion, and I had to be against the sleeve gastrectomy. And there was a surgeon in favor for the sleeve gastrectomy. I already mentioned there at that age, 2012, that after sleeve gastrectomy, reflux could become an issue, and from reflux, Barrett. And if you have that, you cannot do something substantially because you put the stomach in the garbage, I was completely criticized. Why you say that? We have never seen that, etc. We are 10 years later, we know the evolution. Yes or no? With Genko, all the papers are coming out now. So on that part, now all the world has been overwhelmed by the sleeve gastrectomy. That's not going to last, believe me. And don't forget, the sleeve is a non-reversible procedure. Yes or no?
Yeah.
The stomach is away. Stomach is away. Stomach 20 years, it's not an evident choice. Whatever you do for a bypass or OHGB or why, the stomach is still there as a native organ. It's nice, So also, but like in your countries where they're so afraid for the vitamin issue, you are doing OHGB. I mean, it's not a big issue with OHGB, probably a bit more than with the gastric bypass, but the Runway still remains, I think, a bit the standard, certainly for patients with reflux. If you have a patient with reflux, When Nasser Sakran is a good friend of me, he says, even for GERD B, I do an OHGP. We're not going to enter that discussion. I said, but reluctant. If you have GERD B, C, or D, why don't do that through why? You are ensuring yourself that there's no bile coming up. Work safety person. It's not to make it that second anastomosis. I can believe you are adept for technique, because I also start with OHGP, elderly patients, very obese group of patients, fantastic procedure. But we don't do that for 20 years. You never know what the future will bring. When Rutgers described this procedure, when was it, 1991 or something? It takes 30 years to see the evolution, oncologically speaking. For the bypass, we're 50 years along the line. Where is that high incidence of cancer? Of the remnant stomach, we don't see that. We have casuistic examples that coming in, but not systematically. Now we're going to see with the sleeve. I hope it's not going to be the case, because I do a lot of sleeve. But you have to see that after 50 years, my friend, if you operate with a sleeve gastrectomy, somebody of 20 years old, what's going to be the evolution? And let's say after 2 years, he has reflux. Is that not a bit bothersome, with a life expectancy of 70 years old? Yes or no? With the bypass, that's not an issue, because all the studies have been done by Johns Hopkins Hospital. Oncologically spoken, it's the safest procedure, So on that part, for me, it remains a reference.
Sure, sir. Sir, also Dr. Ahmed is from Istanbul and pays regard to you. Sir, what's your message for our, I like to talk more and more, but due to time and limitation, your message, sir, for our youngsters who are just now going to start bariatric surgery.
That's interesting. I just have one important message. Don't lean yourself to do just one surgical procedure, Imran. You know that as well. I'm afraid to see in a lot of countries throughout the world, because we have so many visitors. Tomorrow we have surgeons coming from Poland, Czechia. So many surgeons who have been trained to become a general surgeon jumped into the bariatric. And then they also start with sleeve gastrectomy. Yes or no? Because it's the easiest operation. Do sleeve gastrectomy. I would better say the opposite. You start doing a good bypass, and then you can do a sleeve gastrectomy, not the opposite. And what we see worldwide, I'm afraid a bit, so many sleeve, chuck, I see the stomach stir coming out, but still do a more difficult procedure. Then at your consultation preoperatively, you can make a better choice also. Now, otherwise you're going to be biased and do all those sleeves also in situations where it's not good. So first try to have good surgical skill, make a good anastomosis also manually. In case you have a problem of the stapling devices, you have to turn your needle left to right, backhand, etc. Be a good surgeon. That is very critical. And if you're a good surgeon, then you can do a proper bypass. You can do an OHGP. You can do a bipartition. You can do a SASI, not a problem. But don't confine yourself in one surgical procedure. And just because you have the skills of one procedure, then you're going to say to your patient, that's the best procedure. That's a bias from the start. And that you have to prevent. First, train yourself very good that you can have the skills to do every procedure, and then your decision-making process is going to be much more humble and much more correct. That's what I think.
So much thanks, sir. Really, this is no doubt, sir, one of the best session. And so much thanks, my viewer, that still you are live with us. I think just now I can see from South America, from different Mexico, from different countries, from South Asia, they are live with us. And these sessions are due to your support and due to your guidance. As all you know, we will continue this series of Runway Gastric Bypass every Tuesday, 10 p.m. Dubai time. We are live, and next week we will be with Professor Carl Miller, and also we will talk about Runway Gastric Bypass. Sir, again, really so much thanks for your support. You are always encouraging, always supportive. And after June, because June we will have the sum up session of Runway, and then we will start metabolic surgeries in low BMI for 6 months. And 2023 we will talk about redo surgeries in the next sessions also. We need your support and guidance. Sir, again, so much thanks, lot of respects, and hope see you soon in any international event.
It was my pleasure and my honor to everybody who was present. Back again, a fantastic initiative. Only congratulations that you all get it organized.
Thank you, sir. Thank you, sir. Have a nice day.
see you back in Dubai. Also, at the end of the year, I come to Dubai and we're going to have a good dinner together.
Highly
And
welcome.
I will invite you. Okay?
Great honor, sir. Great honor, sir.
You choose the restaurant. Okay.
Sure, sure, sir. Thank you, sir.
Thank you.
Have a
Bye-bye.
nice time,
Thank
sir. Nice time.